Hi and welcome to another video. Today we'll be talking about iron deficiency anemia. For a brief overview, we'll look at some of the key background information before looking at some of the pathophysiology, clinical symptoms, investigations, as well as the management, before recapping at the very end to finish off the video. Starting with the key background information, iron deficiency anemia is the most common cause of anemia worldwide and affects around 3% of the UK population. Women of childbearing age are most commonly affected, and there are many causes for iron deficiency anemia, and they can vary by age and sex. So premenopausal women are most commonly affected by it because of menorrhagia. In men and postmenopausal women, we worry about GI blood loss, and that is the case until we can prove it otherwise. And then in infants and toddlers, we think about rapid growth or potentially poor dietary intake. And it's also important to consider some of the other conditions such as celiac disease or gastrectomy in those who underwent the procedure. Very brief overview of the pathophysiology. When we have low iron stores, it means that we have less iron to produce hemoglobin. And specifically, we have less heme production in the body. And as we know, heme makes up part of the red blood cells and hemoglobin. That means there is a decrease in the hemoglobin that is available for each erythrocyte, which means we get microcytic hypochromic anemia. Now, in terms of the symptoms the patient may present with, there are some of the general features of anemia, which includes things like fatigue and lethargy, pallor, dyspnea on exertion, as well as palpitations, as well as headache and dizziness. Tachycardia can also be present. That is because your body's trying to compensate by increasing your heart rate to try and deliver sufficient oxygen around your body. But then we also have iron deficiency anemia specific features. That includes things like koilonychia, which are spoon-shaped nails, as you can see on the picture right there. And you can get angular stomatitis, which is sort of an irritation on the corners of your mouth, as you can see on that picture. You can also get glossitis, which is an inflammation of your tongue, and pica, which is craving of non-food items, which has been previously described in literature as well. And you can also get brittle hair and nails. Now, in terms of investigations for iron deficiency anemia, there's a plethora you could talk about, but I'll focus on the key details for this video. Firstly, we'll have a full blood count, which shows low hemoglobin, low MCV, low MCH, as well as high RDW with anisocytosis. In terms of our iron studies, those are very important. We'll have low ferritin as well as low serum iron. However, our total iron binding capacity will be increased, and that makes sense because there's more opportunity for iron to bind because there isn't enough of it in the blood. So the opportunity is there, we just don't have the supply to bind the iron. And our transferrin saturation will be low. We can also do peripheral blood film, which will show us some hypochromic red cells. We can also get something called pencil cells, which are elliptocytes, as well as target cells. And again, we can get anisocytosis and poikilocytosis. It's important, however, to make sure we identify the cause for iron deficiency anemia. So some of the other investigations you may consider, depending on the patient's history and other comorbidities. You can do anti-TTG-IgA to exclude celiac disease. You could do H. pylori testing, an OGD or a colonoscopy to exclude malignancies. And that is important, particularly in all men and postmenopausal women. Management, again, depends on what the cause is. Oral iron is the first line management, usually ferrous sulfate, 200 milligrams TDS. You need to check the hemoglobin response after ideally 2 to 4 weeks. But the very important part is even after HB normalizes, you should continue it for 3 months afterwards to replenish the stores. Then there's also the importance of IV iron. So that can be used in patients who cannot tolerate oral iron, which a fair few people don't, as it can be irritating to the gut lining. So Ferinject is the one most commonly used in the UK. Blood transfusion is also an option, but that is very rarely used for iron deficiency anemia, and that would usually be done only in patients who have very low hemoglobin, who are hemodynamically unstable, or have previous MIs where we want the hemoglobin levels to be 80 and above. So, in summary, iron deficiency anemia is the most common cause of anemia worldwide. The definition varies slightly between men and women, but usually less than 130 in men and less than 120 in women. Causes can include blood loss, malabsorption, and poor dietary intake, which is why it's important to do our due diligence with the investigations. Clinical features include chylomicria, angular stomatitis, glossitis, as well as the common features of anemia, such as fatigue. And management includes oral ferrous sulfate, IV iron, and in certain cases, blood transfusions. Thank you so much for watching this brief overview of iron deficiency anemia. If you have any questions at all, feel free to leave them down in the comments. Otherwise, feel free to consider liking and subscribing for more educational videos like this one.